should not. All right, Jackie, thank you for being on. And as you know, I've wanted to have you on for like 2 years and haven't gotten my act together to get you on, but I'm excited for this conversation. I think this is a really important conversation. So first, tell people what you do.
Well, thank you for having me. And I love that you want to have this conversation with me. So I'm excited for it. But what do I do? So I am a board certified family nurse practitioner. I am a nationally certified menopause practitioner by the North American Menopause Society. And I am the founding nurse practitioner on the clinical team of Electra Health, which is a digital women's health company on a mission to smash the menopause taboo. And I am the assistant medical director at Mays Women's Sexual Health in New York. So I wear many hats, but all kind of collectively towards the efforts of bettering the health of women in midlife.
Yeah, and I love that. I mean, you're dealing with it in so many different settings and seeing so much, and that's why I think you're the expert to talk to on this subject. And certainly it's of interest to me being 45 and entering this period of my life. I've probably already been in perimenopause for a little while now, but I think it'd be really helpful because we don't talk about this enough. We definitely don't talk about sexual desire and libido. We certainly don't talk about it in faith-based communities enough, and it is an issue across the board for women in this age group. But why don't we just start off, we'll get into it gently, just talking about perimenopause. And let's start, what ages can this start, perimenopause? And can you describe a little bit about what happens during perimenopause and what's normal during that time? I just threw a ton of questions. So you start wherever you want.
No, absolutely. So we should start probably by defining what is menopause. So menopause is actually when you've been 12 full months without a menstrual period as a person with ovaries, right? So anything after those 12 months of no period, you're postmenopausal, and anything leading up to that time technically is considered perimenopausal, or the time leading up to the final period. And that window of time can really vary greatly depending on many factors, but on average, it's about 5 to 10 years of perimenopause, which can be a lot of years.
10 years of perimenopause. I mean,
right.
That is a long time.
Yeah. And if you think about it, the average age in this country for a woman going into menopause is 51. But so if you subtract 10, 41 is potentially around the time, or even in your late 30s, to be honest, that we can start to experience changes associated with the menopause transition that might be really subtle and often sort of misdiagnosed or not really recognized by providers who unfortunately just don't receive the kind of training that's necessary to understand how to care for women going through this transition. So that's where
absolutely. I've had clients certainly going through perimenopause in their late 30s, and they also did have a family history of a mother or grandparent going through menopause early. So that's an important factor to consider. So what is normal, which is kind of a funny term, right? Because it feels like nothing is normal during this time, but what can we expect going through that 5 to 10 years prior to menopause?
Yeah. So I always say expect the unexpected with perimenopause, because just when you think you have it figured out, it changes on you. So there are, I think, 34, 35 different possible symptoms of menopause and perimenopause. And some women will experience one or none, and some will experience many, and some will experience different symptoms at different times. There are sort of some classic symptoms that are associated with different phases of this transition. So in the early perimenopausal years, right, when you're in your early 40s, maybe mid 40s for some, you start to experience some symptoms associated with the drop in progesterone. That's the first sort of hormone that is kind of, starting to peel back a little bit for these women. So things we typically see are mood changes. So something you're probably quite familiar with and see quite a bit in practice neuro is, a lot of anxiety. So anxiety, depression, sleeplessness, insomnia. That's another very big one. changes in the menstrual cycle. So your periods in early perimenopause are maybe getting a little bit closer together and maybe a little bit heavier. Those are sort of the early signs. And then as we get closer to our final period, that's considered late perimenopause. This is probably the hardest time for some women because at this point, estrogen is now falling. And estrogen falling is really where we start to experience that classic menopausal woman with her head in the freezer because she's having a hot flash, or weight gain, or bone issues with bones, potentially vaginal issues, low libido. There's a lot.
Dryness. Yep.
Yeah, there's a lot that can kind of manifest. And you really just don't feel like yourself when all this is happening, right? These fluctuations, these rapid changes in hormones that are happening for some women, this is not just a physical, transition. This is also very much a neurologic transition. So it affects the brain, it affects the heart, it affects really every organ system in our body. And so understanding why these things are happening, anticipating the change, being proactive about managing it, and really just being kind and patient with yourself, and kind of telling your partners and those in your household to be kind and patient with you as well during this phase is something that goes a long way.
This is why I always said God made Jesus a man, because he didn't need to deal with all this on top of, not that he lived long enough to go through perimenopause, but I mean, you brought up a lot of important points. And one, I mean, I don't know if you knew this or I told you this, but I started having panic attacks right when I turned in my book, which is interesting. That's a whole other psychological assessment. But I looked up panic attacks in perimenopause, and that is for many women the first time that they experience it. And I think it's kind of a multifactorial issue when that occurs. I mean, it's probably one of the most stressful periods of our life. We're dealing with aging parents, and maybe at kind of the height of our career and raising kids, and all of those things coming together. But then with the hormonal shifts, you certainly, like you said, it affects the brain, it affects the heart, it affects emotions. And we can see all of that manifest during that time. So, I mean, I'd love to talk about all of this, but where do you suggest, let's talk about menopause. So here we see all these fluctuations during perimenopause. Yep. How is that different from when you actually do transition to menopause? Are there the same types of shifts that go on later on?
That's a great question, because I think people need to know that this too shall pass, right? These fluctuations are impacting a lot in our body. Specifically, estrogen impacts serotonin levels in the brain. And, when we don't have stable serotonin levels, we get panic attacks, anxiety. Women who, have a prior history of depression or anxiety, or had a lot of PMS or PMDD, premenstrual dysphoric disorder, a postpartum depression. Those are women who do need to be more on high alert for mood changes and panic attacks and anxiety and things like that during the perimenopausal transition as well. So important to say. But what the good news is that once our hormones are through that final period, our body is desperately trying to maintain sort of like homeostasis, right? An even sense, in the body. And it's looking to do that. And the mechanisms by which it looks to do that are what give us the symptoms. So once we're through and to the other side, and we've kind of like the chase is over, we're going to just, live with our low levels of estrogen for the rest of our lives. There's actually like this exhale that happens in the body, and our body can actually just be at peace with its new state, which is just being a low state of estrogen, which is where you will be for the rest of your life, which for many women is, sometimes a third of their life post-menopause. So this is not a small group of people.
Yeah.
And so, there's just a calming that comes with that. And really the symptoms that follow long-term are sort of the more long-term health outcomes we associate with being postmenopausal, which is maybe your hot flashes are gone and your mood is better, and you've kind of lost, some of that, like what I love to say is my postmenopausal patients really get to focus on themselves for sometimes the first time in all of their life. But, during their childbearing years, getting married, we were like always looking out of ourselves to other people, caring for others. And then you get to this postmenopausal phase where you can really just focus on you. You have time, you probably have more potentially money after, having, spent your whole career working towards something. And then, you get to have this, but we do have to think about cardiovascular disease, about bone health, about long-term brain health, like, dementia, Alzheimer's, things like that. and symptoms associated with sex, right? The vagina itself very much needs estrogen and testosterone. And so without some sort of attention to that, women can start to experience pain with sex, which is something we hear a lot about.
Yeah. And I think that's where we should certainly talk about the desire and lack of desire. And that is what I hear the most of, even in therapy conversations with my friends. I have friends, the ones who are having sex regularly, they have told me it's like we put it on our to-do list. It is a box that we check on our to-do list because our desire does not match the desire of our husbands. And I can say, not that it's on a to-do list, but there's certainly a mismatch in desire between me and my husband. He is Puerto Rican. I'm not going to stereotype, but it works in this case, that stereotype. And, it has certainly been a place of conflict. And the interesting thing is because when I was going through school and took, human sexuality in grad school and all of that, the psychology of sex, they talked about how it is a multifactorial issue. I am attracted to my husband. I love my husband. We have a wonderful relationship. And still my desire is much lower. So, and those things don't always affect desire. And I'm tired. At the end of the day, I am tired. So, Jackie, solve this problem for me.
Oh my goodness, I wish I had my magic wand. Well, you just said a lot of things that were spot on, Neuro, because we are tired. Women in their 40s are doing it all. I mean, we are trying to be moms, wives, career women. We're trying to carve out time for self-care. We're tending to quite a bit. We might be dealing with aging parents, like you said, layer in some sleeplessness from maybe, hormonal fluctuations that are less than ideal, or night sweats or urinary symptoms. Like sleep is such a big deal for women in this phase of life and just has to be prioritized in order to, maximize a lot of other things. So I did just want to say that because I feel like sleep is just such a big deal.
Yeah. And hold that for a second, because I did decide recently, because I was someone who did not get sleep for most of my life, and my husband doesn't either, especially going through surgical training. But I had to come to a place that I was like, if I'm not sleeping because I need to get all of this stuff done, I am absolutely doing too much, because this is not healthy. This is not the way I was created. My body was created so that I can thrive. So I have to stop. I can't do that much. I can't take it on, even if I feel like it's essential. So yeah, I agree with that. I made that decision. I'm still working on keeping that consistent, but continue.
Yeah. Sleep. I mean, that's a whole other topic unto itself about ways to sort of strategize around that, but we just can't run the same rat race we were running in our 20s and 30s. And so
yes, it has to change.
It has to change. We're doing a lot. So sleep is paramount to sex specifically too, because there's actual studies and data to show that women who don't sleep, their sex life is impacted radically. So sleep for sure. Let's see. So there's a lot that goes into what makes a libido, especially for women who are in their 40s, perimenopausal or beyond. One thing that comes to mind certainly are hormones. So estrogen, the loss of estrogen absolutely impacts sexual drive, but so does testosterone. Testosterone is a very important female hormone. We think of it traditionally as a man's hormone, but women have actually, during their reproductive years, more testosterone than they even do estrogen. So it is in abundance. It is responsible for desire in women. So it will impact your ability to get aroused. It will impact, quality of orgasm. We have testosterone receptors in our brain. There are some studies that show that women who have higher testosterone levels, and I don't mean high like a man, I just mean like good quality testosterone physiologic levels for a woman, are more confident, are more willing to take risks, like financial risks. So we know that it is an empowering hormone. It's a hormone of vitality. So it actually directly impacts dopamine in the brain. And dopamine is a powerful motivator. I'm sure you know that, right? So it's a source of motivation. It's a source of vitality. And so when testosterone is low, you could see how that would then directly impact your motivation to have sex with, with
Yeah.
yourself, with your partner, with anybody. So,
And interesting you say dopamine because it is a reward neurochemical. So if that is being released, there's a greater likelihood to want to do it again, right? So if the dopamine is lower, there's going to be less, like you said, motivation to continue whatever that practice is.
and to that point, like, what is the reward, right? Like, we can't expect you to, I can give you testosterone and increase your dopamine, but if you're not finding pleasure in sexual activity, then why do it? I mean, we are very simple in that way. It's not a lot that's simple about female physiology, but in terms of pleasure, like, we're not going to do anything that doesn't bring us pleasure, at least not willingly. So you have to think about libido, and this is like what we talk about a lot in practice. For women specifically, we're not made to have the spontaneous desire that men are. Our testosterone levels aren't high enough for that. Some women feel that way maybe in their 20s, but then we have kids and now we're in our 40s and we're looking around like, what happened? You can't wait for sex to just happen, right? You're going to be waiting a really long time. You actually have to be intentional about it. You actually have to, you said it's on the to-do list. And while I get that sounds terrible, it actually really isn't.
Agreed.
Because when you put it on your to-do list, especially when you're in a relationship where there's a higher and lower desire partner, it does a couple of things. And this has to sort of be like a contract that you have with your partner, where your partner knows that it's going to happen. And this is when it's going to happen. So it's scheduling it, right? On Friday night, this is what's going to happen. You can then start to get your head in the game about it. You can, start to fantasize in the morning. You can make sure you're putting on an outfit that makes you feel good about yourself. Arousal actually for women starts way before you get into the bedroom.
Absolutely.
It's something you have to like bring in with you. And so if you go in already feeling like this is something I've committed to, this is a choice I've made, I wanted, I want to have time for my partner, this is going to bring us closer together, like whatever the motivation is that's bringing you there, capitalize on that, make it the most pleasurable experience it can be. There's lots of ways to do that, right? Women need to find out what feels good to them on their own a lot of the time before they can even talk about that with a partner or explore that with a partner. And many women haven't spent time doing that, unfortunately. So that's something to do, on your own even. And then what women will experience is more of you have this positive sexual experience, you and your partner feel close. It's in the aftermath. We have this responsive desire, this idea that you looked and you said to yourself, well, I didn't really want to go to the party, but I went to the party anyway, and I had the greatest time. And we've all been there, right? You didn't want to go do something, but you're so glad you did. Say that to yourself after, whatever is done, because that will create a feedback loop in your mind to say, I had a really good time. That was great for my relationship. We should do that more often. And that's how you sort of get out of the spiral of, not wanting to have sex and just sort of waiting for it, avoiding it, hiding in the bathroom, hiding in your car, like whatever the things are we do to like avoid,
avoid having sex. I think that's such an important point. Those are really important points. And in therapy too, we tell people, put it on your calendar, right?
Mm-hmm.
Schedule it like you would a commitment. And it's all the things you said are just making me think of so many situations that I've been in. But a couple things that I've seen too is it can, and obviously if women are not experiencing physical pleasure, if there is pain, that needs to be investigated and treated like it is a problem. So we're not saying continue in that pattern, but I think in terms of motivation and increasing motivation, the things you talked about are really important. And one thing that I've seen, especially between me and Ed is probably listening in his car driving to New Jersey. So I hope you're okay with me talking about this. But the worst thing for him is when I say it's going to happen and it doesn't. Yes. It's better for him to be on the same page and be honest about, hey, it's not happening, than to promise and not deliver. And he feels, we've explored this, a deep sense of rejection. And I don't feel rejection in that way. Obviously, I feel rejection in other ways, but he does. And it's interesting because I've been doing a little bit more studies just in men and sexuality and this feeling of rejection, and especially for a population in particular that didn't necessarily feel connected and a deep sense of unconditional acceptance or love growing up. Oftentimes, those men do find that connection through sex. And they're historically in their life, you may trace different moments where you can see that beginning to happen. And not saying that's necessarily the case for my husband, but certainly interprets it differently than I do. So I think just communicating honestly about that is so very important. And then the other thing I was going to say is in terms of reward, some of my girlfriends and I have talked about when our husbands are having sex, they are happier and they are nicer to everybody in the family. So,
True.
right? So I notice when it's been a while, I have a grumpy husband and that grumpiness comes out at everybody. So I have called that, and he and I called this in our talk, bring sexy back, TOFTT sex, take one for the team sex. Um,
I love that.
so one day my kids and we will have that talk like, you don't know what your mama did for you. Some days, but
Yeah. But really, I mean,
yeah.
it's also for, if you want to think about it strategically, we certainly can. Like, there's times when I'm like, wow, there's a lot of things I'd like to have happen around the house this weekend, perhaps. This isn't like a bad idea.
Oh my gosh.
But
I
no,
have one girlfriend who's super intentional with that motivation.
there's no shame in the game. But
No.
listen, like you said something really important, and that is that men, and I see this, men a lot of them need a physical connection in order to have an emotional connection. And for women, it's sometimes the opposite. Women need the emotional connection in order to feel safe to give of themselves in a physical way. And so those two things can be a bit conflicting at times. So finding a way to sort of empathize with the other person's, philosophy on sex in a way, just even doing that can bring people together in a way.
Yeah. And absolutely. And finding out which partner are you, right? Because
yes.
I mean, there are women who need that as well. Like we talk my sister Chrissy, I'm gonna blow her up right now. She's more like the man in the relationship. We talk about this all the time, so but in general, population wise, yes, women and men, we are created differently in terms of that aspect of what we need. Sure.
Yeah, absolutely. So yeah, there's a lot back to your question about like, what can we do about libido in midlife, perimenopause? I think it's also important to look at the way, some of the medications you're taking, for instance, right? That's a lot of times people don't realize that the oral contraceptive that they're on to manage the symptoms of perimenopause, right? That's one of the most common things that we prescribe for perimenopause are birth control pills, because it evens out your hormones. It's a steady state. And so you don't get these wild fluctuations. But in doing so, you actually, when you take a combined oral contraceptive, you're actually completely getting, flushing out all of the testosterone in your body, essentially. And again, so you don't have that testosterone to drive you for sex. So there is a trade-off there. And I don't think that that's something that doctors often counsel patients on who they're starting on birth control pills.
And of course, antidepressants, anti-anxiety medications. And there are some that have lower side effects than others. So if this is an issue, it's definitely something to explore with the provider to get on something that may be more conducive to libido.
Yeah. And there are 2 FDA approved medications for low libido or hypoactive sexual desire disorder, which is the clinical diagnosis for this. And what that is actually is like, if you don't want to have sex at all and you're cool with that and it doesn't bother you and you're not like mad about it, guess what? There's nothing wrong with that.
Right. And your partner too, right?
And
if you're a match in that way. Yes. Yeah. And that's why
nothing wrong. It's not pathologic. I think we apologize this a lot, but it isn't always a problem or an issue. It's just a new state of being. But if it's a problem and it's distressing to you, and we see this in women who previously have had robust sexual lives where sex was a really important part of their identity, was a really important part of, their relationships. And then all of a sudden they hit their, midlife years and it's waned significantly. And they're like, whoa, what's happening here? I miss that. I want it. That's HSDD. And so for women who've not yet reached their final period, there are 2 FDA approved medications for that specific condition that address neuromodulators like dopamine, like norepinephrine and serotonin in the brain. Flibanserin is one, and bremelanotide is mouthful, but Vyleesi is another. They're not slam dunks, in my opinion. A lot of this, nothing for women's libido is a slam dunk. Like, let's be perfectly honest. It's part of a multimodal approach, which often involves shifting the way you think about sex. optimizing, dopamine levels in the brain, optimizing testosterone levels in the brain, making sure that your thyroid hormones are in a good place, because thyroid is a common, issue for women in their 40s, directly impacts testosterone levels. Cortisol, stress, all the things that we think about when we think about what goes into our mental state, right? All of that needs to be looked at holistically by somebody who kind of gets all the different facets of treating women in perimenopause.
Those are really helpful. And just to go back, and I want to ask you about other treatments, but just to go back to what you said about if you're not having sex and your partner too is okay with that, that's actually a sexual match. And you are okay. It's when there's a sexual mismatch where it can cause problems in the relationship. Because I have women ask me all the time, how often should I be having sex? And that in a relationship, depending on how long you've been together and whatever it is, but that's really a conversation between you and your partner. But I will say that not having sex does not mean that you should not be experiencing intimacy in one way, right? So if you're not having sex, but then you're not intimate at all in any way, you don't feel connected intimately to your partner, then that becomes a problem, right?
Yep.
Because that should be fostering intimacy in our
Yes.
relationship, right? So
not have to be sex. Intimacy can just be a closeness that is acceptable to you and your partner. But I also do want to make the distinction that, sex does not just mean sex with a partner, right? Sex can also mean, intimacy or sexual, activity with yourself, which is what is important to sustain us. I mean, it's a pillar of wellness in a way, next to it's like the ugly stepchild, but it is actually next to sleep and diet and exercise. Sexual activity releases powerful hormones, oxytocin into the brain. It helps us connect with our bodies. Unfortunately, women get a lot of negative messages about solo sex and self-pleasure and all of that from a young age. And there really is no better way to know what it works for you and to bring that into a partnered relationship than to explore, your own sexuality in that way.
I will say it's really important too, especially in the context of a marriage. Not that it should be a substitute, like, okay, this is what I'm doing. I don't want to have sex with my partner. But especially so many women have shame issues when it comes to their body. They're not comfortable with their own sexuality. And that could be something in that context that really actually helps the whole marriage, right? Especially if there's openness about it. And you're getting used to your body and comfortable with your body. And yeah, and especially I think for people who grew up in faith backgrounds, everyone has their own beliefs, but the messaging so often is negative around sexuality. And we believe God created it for a purpose, and it was to be a powerful experience. We're not given that message necessarily in the right way growing up. So there's this hesitancy of talking about it. Once women who've grown up in that environment do get married, it's like you're told don't, and all of a sudden okay, now go to it and be amazing and be on call all the time,
Right.
And it's
our
brain doesn't work that way.
No.
We built up these neural pathways to think about it differently, and now it's hard to get comfortable with that idea for many women. So
you're right.
Everything.
We see that a lot too in the form of pain with sex in younger women. I see a lot of vaginismus, pelvic floor hypertrophy, vulvodynia, that manifests as a result of women internalizing shame about their bodies and really being uncomfortable with what is even going on down there. Women are afraid to even look there or touch there, or, and it becomes almost like this vestigial organ that is just ignored until, like you said, it's time to get pregnant, or to, be in a marriage. And all of a sudden we're expected to just be the sex goddess, that you weren't yesterday. And so that's really, I think, unfair to women. And it really there's a lot of education that we need to start doing with, with girls at a younger age, just about body acceptance and understanding that your vulva, your vagina, they're all part of you, just like your arm or your, the hair on your head, and requires the same attention.
Absolutely. And I think that is a conversation that we need to have with our daughters and young women, and women especially, also who are getting married, because sex changes in a marriage, and to have kind of, not to crush all their dreams, but realistic expectations
Mhm.
what this can be like. I think that's really important.
Yeah.
My dad does some work around this, which people think is so funny that it's my dad, but like he has three daughters. He's been an OBGYN his whole life. Like, why wouldn't he? Right. So, do you know anything about the O shot or the P shot and those treatments for low sexual desire? I mean, from what he says, he's had good results with those treatments. What are your thoughts on them?
So yeah, so this is where it gets a little tricky because definitely, the society that governs sort of women's sexual health is called ISWISH,
Mm,
and North American Menopause Society. Like they would say like a hard pass on the O shot, right?
interesting.
For those who don't know, the O shot is platelet-rich plasma that is your own blood. So it's like the healing power of the platelets in your blood that's harnessed and then re-injected in different places. And like Ed, your husband would probably know that it's used in orthopedics quite a bit,
Yeah.
and it really just helps heal. So for men who are experiencing some erectile dysfunction, it can be injected directly into the penis. For women, it's injected directly into the clitoris and in the anterior upper portion of the vagina. I have done this procedure for women. We do offer it. I definitely think it's yields sort of mixed results. There's some women who we do it on who say it's amazing, and then there's some women who said that it did absolutely nothing. The good news is
Hmm.
that it really isn't that harmful, right? It's your own, aside from there being a needle injected somewhere and that being a bit uncomfortable and
Ouch. Like,
constriction. Yeah,
seriously. Yeah.
exactly. You're not going to have an allergic reaction to it. It's literally your own stuff going back into you in a different way. So,
Mm.
it's something that's out there. I think we have way more powerful tools for women than the O shot, like testosterone replacement therapy.
Yes, that
Is
was another one.
definitely, yeah,
Yes,
is a
that
big
he
deal.
does. Hmm.
Not FDA approved, unfortunately, not for
Right.
lack of evidence or for lack of trying, but just a bit more because we have yet to really embrace the idea that testosterone is important for women in any meaningful way on a policy
Or
level.
women's sexuality is
For women's section, I
significant,
mean,
right?
that's a whole podcast in a row. That's a
Oh,
whole podcast. But
yeah.
yeah, so but that doesn't actually stop us from using it in practice. And there are actual guidelines from the societies that look into this and research it. And you could look that up on the internet, and any doctor or practitioner could go and look up how do I treat women for HSDD with testosterone, and it's there for you. So it's something we should all be kind of educated on. I do quite a bit of it in my practice. It really helps a lot of women. Women feel so much better. And the combination of menopausal hormone therapy, right, in the form of estrogen and progesterone for the right women who are candidates with the testosterone, it's like this peanut butter and jelly effect. And those two things
Mm.
together really bring women kind of, you see them flourish again in a way that, all the diet and exercise could never, even though those things are super important. Hormones are
That's
powerful.
so helpful. And how do people contact you if they have questions?
Absolutely.
I can
So,
put your info on the show notes, but what's
yeah,
the best way to get in touch with you?
sure. So, I mean, an easy way to get in touch with me is just to email me.
Hmm.
You could email me at jackie@electrahealth.com. We
Great.
do offer sexual wellness consultations for, women all over the country. So I don't know who, your listeners are in a row, but, for women who
They're
are
all over the world.
all
Yeah.
over the world. So yeah, so sexual wellness is it's basically a 30-minute education session about what we talked about today on a little bit more of a personalized level. And then for women in New York, we do offer, actual telemedicine and care via Electra Health. If you are living in Westchester County, New York, or in the tri-state area, I can see patients in person at Mays Women's Sexual Health, which is in Purchase, which is in Westchester County. So any
Great.
of those are
Great.
options. Yeah,
Jackie, this was super helpful, and I'm glad that we were able to have this conversation. I know it's going to help a lot of women, and I think just the takeaway is if you have low sexual desire, you don't have to live with that. There are things that you can do, whether it's cognitively, therapeutically, lifestyle change, or actual treatment.
yeah,
This is important. They are important, you are important, and there's ways to change this and get help and live a fuller life in this capacity. So thank
absolutely.
you. Thank you for sharing your expertise. It was awesome. And we'll definitely have you back on again.
I would love that. Thank you for having me. This is great.